like to disclose that I have sent out a survey to the Health Ed database last year, exploring health professional attitudes, knowledge and practices regarding FGCS, and some of the findings of that study will actually be talked about in this presentation. And as mentioned, of course, the RACGP responded to the call from GPs for information regarding female genital cosmetic surgery by agreeing to launch a book that was authored by myself but supported by authorities both locally and from the United Kingdom. And what we found from the survey last year was that a good proportion of GPs, in fact, almost all GPs had actually been, were aware of female genital cosmetic surgery, that nearly all of them had been asked at some time for information regarding these procedures, but that very few, less than 50%, felt confident in advising patients regarding this set of procedures. So, to start with, what is FGCS? It's a group of procedures that are designed to modify the aesthetic and functional aspects of female genitalia. It's non-medically indicated, and when we talk about functional aspects of the discomforts that women complain about, or symptoms that women complain about, it could be anything from chafing to tight discomfort during sporting activity, dyspareunia due to invagination of the labia minora. The trimming of the labia minora, also called labiaplasty, is known colloquially as barbieplasty or design a vagina surgery. And it is the most common form of FGCS that's performed around, in fact, it constitutes around 50% of the procedures. It's often performed in combination with clitoral hood reduction, which is aimed to reduce, expose the clitoris itself. And other procedures that are performed under the auspices of FGCS include perineoplasty, aimed to strengthen the pelvic floor in the FGCS setting. Primarily, it's aimed at establishing penile pressure with coital thrust. And there's also vaginoplasty, which in its original form was vaginal creation and gender reassignment procedures, but in the FGCS setting refers primarily to tightening of the vagina or vaginal rejuvenation, designer laser vaginoplasty. Now, this is an interesting area which is now currently being researched by some reputable gynecologists, so it'll be interesting to see what comes of these studies with respect to treatment of vaginal atrophy, non-hormonal treatment of vaginal atrophy, but it's probably a space that we should watch and observe closely. Other procedures include hymenoplasty, also called revirgination, which is designed to restore the hymen, vulval lipoplasty, G-spot augmentation, and orgasm shot are very controversial, of course, because they involve injecting material into parts of the genitalia that actually anatomically are also ill-defined. And a key aspect of it is, of course, of the whole set of procedures is that anyone can perform the procedures. Anyone with a medical degree can perform the procedures. And that in the United States in 2013, the Society of Plastic Surgeons posted that their statistics and indicated that there was an exponential climb in the 1 year of labiaplasty procedures being performed. It climbed by 44% in 1 year, becoming the fourth most popular surgical procedure following lipoplasty, liposuction, breast augmentation and rhinoplasty. Now, these figures are being matched in Australia, United Kingdom and Canada. Of interest also is the fact that women aged 15 to 25 are also having these procedures performed as frequently as women between the ages of 26 and 45. And there are currently no criteria for surgical standards. And the Medicare statistics in Australia represent really the tip of the iceberg. And the government, the health department, was concerned about this sort of unprecedented climb in requests and issued a review of labiaplasty procedures in November of 2014. Since the review, there have been stringent rules applied as to who qualifies for medically indicated labiaplasty, and the incidence for requests has declined within a very short space of time by 28%. And we may well see this decline further. And what this indicates is that there are probably more socio-cultural forces than medical reasons for this procedure to be requested. And there are currently no evidence-based procedural guidelines. Female genital cosmetic surgery should not be performed in girls under the age of 18, and this was issued as a statement by the British Society of Paediatric and Adolescent Gynecologists and the Royal College of Obstetricians and Gynecologists in 2013, because genital maturity is incomplete. However, when women are concerned about their genital appearance, they might look online and try to find answers for themselves because they're embarrassed to actually ask directly. And what the other confusing factor about this whole discussion is that the terminology used can cause confusion because they are medicalised terms, and the cosmetic industry redefines the patient as a consumer and uses advertising to promote a product as an uncomplicated lifestyle choice. Now, this may well be okay for some, but where there are elements of anxiety, where there's a lack of information, and where the information is skewed towards promoting a particular ideal that doesn't represent reality, then questions should be raised about the ethics of that sort of marketing. Exploring websites does not give answers to such questions as what constitutes labial hypertrophy or normal labia, or what even is the function of the genital tissue that's being removed, and what are the potential complications. Only too easily you'll find that the sites reveal before and after shots, before labiaplasty, after labiaplasty. And associated with these images, very often there are statements along the lines of more than 30% of women have excess genital tissue or large labia, and that this is a problem. Now, the woman who doesn't really know much about genital diversity and who has concerns or may well find that this is what she's expected to look like. And research that I conducted through the University of Melbourne in 2013-14, we interviewed 21 students, female students, regarding knowledge and attitudes towards FGCS and knowledge of their own genital appearance. And all participants, the 21 participants, identified, voted D, the final image there, which was the hairless, prepubescent-looking appearance, as the ideal. And 3 of those students were in fact biomedical students. They had very little knowledge of genital anatomy, so when we showed them a plain diagram and asked them to actually fill in the anatomical structures, they didn't know really the difference between labia minora, majora, clitoris, urethra. Now, there are social trigger points, obviously, that are influencing attitudes and knowledge, and one of them seems to be the removal of genital hair, which has exposed genital tissue that was previously concealed, and women don't get to really see each other naked very often, unlike men, and our genitalia is hidden behind a cloak. And with current social trends changing and fashion trends changing, a lot of the gym gear and sportswear really outlines genital contour, and it's resulted in the evolution of terms that are camel toe. They're unsavoury terms. Of course, other social trends are changing too, and adornment of genital areas and social attitudes towards this are also changing, tattooing and piercing. So we've got changing attitudes, but with it alongside that, we've got some sort of obscure line between normal and diverse and desirable. And the question is an ethical one. It needs to be asked, are women being subjected to, another form of control that undermines their self-worth and reinforces the notion that their primary role is to be desirable? Now, factors other than just fashion and genital hair removal that may be impacting this include Australian censorship laws. They prohibit the illustration of labia minora, the exposure of the clitoris, and invariably represents the genital area as that of a prepubescent girl in adult women as the norm. And this contributes to the general lack of knowledge and understanding about female genital diversity. So we've touched on certain factors, socio-cultural factors that are changing, that are increasing the demand or influencing the demand for FGCS. And in the survey, what we identified was that, clinicians suspected, the doctors suspected psychological issues in around 50% of the women who requested FGCS. Of these conditions, 67% considered anxiety being a key concern, relationship difficulties in 59%, body dysmorphic disorder in 55%, depression in 50%, sexual dysfunction 42%, eating disorders 28%, a history of sexual abuse in 24%, and domestic violence in 12%. Which is pretty interesting given that the GPs that responded to the survey, more than 74% were women's health experts and 77% were female GPs, and the average length of time they'd been in practice was 22 years. So we're talking a cohort of GPs who have quite a bit of experience and wisdom. And 41% of the GPs who responded in this survey also had a mental health interest. So one can assume that this is not an inaccurate set of figures. And if a woman's concerned about her genital appearance and she looks online, there's going to be a bombardment of labiaplasty advertising out there, and very little out there to counter the imbalanced perceptions that are being promulgated as a norm. Now, the question, of course, is how should we as GPs manage such requests? Well, our first role is, of course, to listen to the patient and assess their degree of concern and address each and every one of the symptoms delicately. Assess, how does it affect their personal life, their intimate life, their sexual relationships. It's important not to medicalise a lot of the symptoms that women present with, such as chafing or irritation due to tight or small clothing. And when we suspect mental health issues or relationship issues or sexual abuse issues, we should refer accordingly. Offering to examine the woman is also very important, and sometimes they'll accept an examination at the time and sometimes they won't accept an examination at the time. If not, then offer a referral for an examination or make another appointment for an examination and a second appointment. If the patient is under the age of 18, a medical chaperone should be present. And having a baseline of a psychosexual history and gynecological history and medical history is also very useful. And asking questions about discomfort with or without sex, and asking about the person's intimate relationships and their self-esteem and confidence and their ability to function. And it's important to be as non-judgmental as we possibly can, because what we say has an enormous impact. The expectation also is that we know something about complications of FGCS. Now, a lot of us don't. We can certainly claim that, or assume that bleeding, wound dehiscence and infection and scarring can occur, and they do occur. We don't know statistics yet, and they're not published anywhere. But the ones that are of a particular concern and peculiar to these sorts of procedures, of course, are the sensory neural complications secondary to poor healing, which can result in long-term scarring and painful sex. And sometimes too much genital tissue is removed, resulting in chronic pain with or without intercourse, such as when the clitoral hood reduction is performed too enthusiastically. And a lot of women don't realise that this is actually incorporated as part of the labiaplasty. So there are possible long-term psychological complications and reduced lubrication, because the role of the tissue, of course, is to lubricate. And Helen O'Connell, urologist, in one of her seminal papers, outlined that removal of genital tissue, labia minora, is actually not just like trimming hair, because the tissue is actually enriched with many nerve fibres and many blood vessels, and it's part of the primordial phallus. So we don't really know much about the long-term consequences. They haven't been researched. But one of the big names in LABIAPLASTY and FGCS out of the United States, Gary Alter, who has performed probably the most labiaplasty procedures in the world, has now set up a practice called botched labiaplasties. And he's admitted that more than 50% of the procedures he's actually had to perform are actually review procedures on women who are dissatisfied with surgery from previous surgeons. And this raises concerns about the frequency of this. So part of what we do is educate our patients, and we have specific tools now that we can use, and one of them is referring patients to the Labia Library, which is an online website. It was launched by Women's Health Victoria. I was very fortunate to be involved in its inception and also edit some of the medical content of it. And the Labia Library website actually won the Victorian Premier's Women's Health Prize last year. And other sites online that you can find are the tabletop book, The 101 Vaginas and Femalia by Jodie Blank. When we talk to patients about their genitalia, it's an opportunity to educate and talk to them about the sensory, neural and functional aspects of their genital anatomy, and use simple diagrams and encourage women to have a look online. Again, Labia Library is a very useful tool for this. They can do that in the privacy of their own home if you're embarrassed or they're embarrassed to talk about this themselves with you. So the GP who addresses a woman's concerns can actually deflect a lot of unnecessary anxiety and surgery. One of the respondents of the surveys actually, I found the statement was actually very nicely worded, and I've just plucked it out. She states, "At first pap smear or when examining a young woman for the first time, I will always comment, everything looks entirely normal. The response is always relief, even when I wasn't aware there was any anxiety beforehand." And I'm sure that many of us will have had that experience ourselves. So when a patient does come in requesting surgery, refer ideally to a gynaecologist for a second opinion if your own advice hasn't actually helped reassure them. Gynaes see more genitals in a professional lifetime than anybody else, and the referral should state that it's for an opinion, not necessarily for surgery. And where there's mental health concern, we should refer for counselling, and if the patient is less than 18, they should be referred to a specialist adolescent gynaecologist only, and also mandatory psychological assessment too. We should warn women against going overseas, because of course there's very little possibility for recourse if they're unhappy with the outcome. And we should get a baseline knowledge of what a woman knows about her own anatomy and its functions. For our own use, I think looking at peak body statements is very helpful, because there's a whole host of research out there and statements made by reputable colleges that are all saying pretty much the same thing. Educate women, let them know that normal is diverse, and assess for mental health issues, examine them and be sensitive, and if they're under 18, refer to a gynaecologist who specialises in adolescent gynaecology. The medical board says that there should be a cooling off period for all patients and that there's psychological assessment necessary for under 18s, and that cosmetic procedures, especially genital cosmetic procedures, are very different to other forms of cosmetic surgery. And Joanna Flynn made a public statement last year that what we need to do is keep the public safe. Female genital mutilation, female genital cosmetic surgery. Some say it's a very fine line of distinction. And if you observe the written word of the World Health Organization, FGM defines World Health Organization defines FGM as all procedures involving partial or total removal of the external genital, female genitalia, or other injury to female genital organs for non-medical reasons. And there's some argument by some that it's not dissimilar to, that FGCS is not dissimilar to FGM. However, there is, in fact, I'll go back, because there is now a movement out of the United States that is claiming that female genital mutilation should actually be referred to as female genital alteration or modification, and that some minor forms of FGM should actually be permitted in the Western cultures so that we don't really demonise the societies who practice FGM for social and cultural reasons alone. And they're saying that there's too much of a similarity between FGCS and FGM for us to be... so I'll just wrap up very quickly. The medical profession is also influenced by socio-cultural beliefs and systems, and that's something we need to be aware, and that we also need to be guided by our peak bodies and provide our patients with the best advice possible, which has been recommended now by the college guidelines as informing patients, examine the patient, listen to the patient and refer for mental health issues, educate patients regarding tools that they can use to educate themselves with, refer to a gynaecologist for opinion, and if they're younger than 18, they should be referred to a specialist adolescent gynaecologist and be given mandatory psychological testing. Thank you for your time.